I am going to remind folks who are online that if you want to participate, hopefully you have registered at the other link that Caroline mentioned. And if you want to join in on the conversation, if you can raise, I assume, their virtual hand. We have folks here who are monitoring that and who can work with our facilitators to let folks know that you would like to join in on the conversation. So with that, I'm going to turn the mic over to Laura and to John to facilitate our engagement.
I'll start us off. Hello, everybody. I'm John Sapero. I'm a person with HIV. I'm also a PACHA member and the current co-chair of the Ending the HIV Epidemic Committee. We're going to make this a really easy conversation to have. And the first thing that I would like you to do is, if you have a name tag, literally or figuratively, I would like you to take that off and be open and honest and candid with your thoughts. And that's regardless of whether you're a person with HIV in our audience, a PACHA member, a member of a service organization or a public health program, or a member of a private program, a private partner, pharmacy, what have you. It is really important that we have a coordinated, open and honest conversation among all of you about what you're doing. And I know that some of you may have some sensitivities around your organization and what you can or can't say. So if you can do that as an individual sitting in the room and not a representative of your organization, that would be fantastic. Laura and I are going to walk you through questions around the 4 goals of the National HIV strategy. So we're going to talk to you about your thoughts on what we can do to prevent new HIV infections. Then we'll talk to you about improving HIV-related health outcomes of people with HIV, reducing HIV-related disparities and health inequities, and then finally achieving an integrated, coordinated effort that addresses the HIV epidemic among all partners and all stakeholders. Why it's really important that everybody in the room has a voice in this conversation. We will attempt to remember to go online after we have comments from the room. However, if I do forget to do that, or if Laura does, please let us know and we'll make sure that we get those online comments. And then finally, if we have some time, we'll ask you some questions around local and national things around innovations and some other things that we could go through. Laura, do you have anything to add? Or no? All right, so we'll jump in. So the first thing that we want to talk to you about is really thinking about what we need to do to provide greater impact in terms of what we're doing to prevent new HIV infections. And I think we've talked a lot today from the perspective of national and local community partners. What are your thoughts around that? And do we have, Carolyn has the microphone for folks to provide their comments, and so somebody.
Hello, Laura Fox, PA. Nice to meet y'all. I've heard some really great things like, hey, let's use nurses. Yes, please. Let's get, let's change our age group. You don't want to know what I see in my over 64 population, what they do. It's crazy. So when we talk about that, though, I feel comfortable talking about those things. I'm known as the person who has no filter at work, and not all providers can do that. So what I'd like to suggest is some talking points. We just recently had something come up at my organization. Someone sent out, hey, it's against my beliefs to prescribe birth control. My first response, yeah, right? It's like, oh, whoa. But you know what? That's that person's beliefs. And they were actually searching out to say, okay, how do I provide this patient with the appropriate care to make sure they still get taken care of? So I think identifying providers, whether you're in a specific organization or safe spaces, or telling providers they are allowed to say, you know what, this is not my wheelhouse. However, I'm going to get you to someone who is going to be able to help you. And hopefully just by that little bit, allowing the providers who Do I believe in that? No. But by telling providers they can refer to somebody else, especially in this day and time, can prevent us from hearing that I was told I can't get PrEP and we don't do it. Or I was told just last week, I was told I can only get STD testing once a year on my physical. So allowing people to refer appropriately in this time of challenges that we have.
And I'm just looking over Stefan's shoulder, creating talking points for providers, identifying safe spaces, and allowing people to refer to providers that will do what the client has asked them for. Thank you. Other folks in the room?
Can we comment on things?
Yes, please.
I think that's great, but I want all providers to do the right thing. So can we add to, your list, provider, better provider, education and things like that.
Thank you for that. Other folks in the room, folks at the table. All right, I'll go online and see if we have any comments from anybody. No. No. All right, Laura, I'll move over to you for a second.
Sure. Going back to the first question, I just wanted to ask, are there any special considerations for HIV prevention with communities of color that you haven't seen in the strategy? If anyone has anything to share.
One of my concerns very candidly is that 150,000 people have just been kicked off of Medicaid in the state of Arizona. And so when we think about new infections, that's 150,000 people who are not going to be able to get preventative care. And so I don't have the solution, but I just wanted to bring that to light, that it's very concerning. Thank you. Especially in communities of color.
Yeah, I definitely agree. I know our Native community is impacted by that as well. So thank you for raising that.
In addition to that, the state of Oklahoma is implementing a statewide EMR system that is an automatic opt-in. And for our smaller communities, that allows any provider that has access, it's a requirement to use that statewide EMR system that goes into effect July 1. And anybody can see those patient records. And so I don't understand I'm assuming there will be a stay on the implementation date or the activation date, but that's an issue because just like as we talked about in the smaller communities, someone may walk in and half their relatives work at that clinic because it's the main employer in that area. And now someone can't be on PrEP safely or and not like keeping their privacy about that piece of themselves.
So concerned about the system in Oklahoma that's being implemented.
Okay, Shine.
Okay, Shine. Okay. Thank you for raising that. Definitely confidentiality is a concern in our communities. And so that is concerning that their information could potentially be breached through that system. Okay, we'll go on. And anything else as to prevention? Yes.
I think you raise a good point about the Medicaid redeterminations happening right now, because we're seeing all these numbers that are coming out, but none of the data is extrapolated to disease states or to prevention. And that's going to be a concern. I mean, I think, hopefully Kaiser or somebody will eventually be able to do some sort of report on how many people with HIV were lost to care. But the prevention piece, like how do we even get our heads wrapped around how many people in that role that lost Medicaid could have been benefited from prevention and then the increase in diagnoses because of that. So my comment is basically around data and how can we use data and how can we capture data and how can we continue to use data to help end HIV.
Thank you. We're noting that down here under Medicaid. Did you get data? Okay. Got it. Okay. We do have that down. Thank you. Do you want to go on to the next one?
Yeah, it's your question.
Okay. So next one is focusing on the second goal of the National HIV Strategy. It's focused on improving HIV-related health outcomes of people with HIV. How can we improve outcomes? Do you have some suggestions? Yes.
So in light of the information that we heard today, especially from Mr. Curley about the integration of Western medicine and Native medicine, that alternative and complementary therapies have been kind of banned by the Ryan White program for more than a decade now, for close to 15 years. And it would be nice if that could be reincorporated into the Ryan White program. Not just Native practices, but there's also a tradition, a Mexican tradition that I understand called curanderismo, which, is along those lines as well.
Thank you. I know that has come up a lot in discussions I've been in with alternative therapies even being reimbursed by Medicaid. So Ryan White, Medicaid, just broadening what's reimbursed. Definitely. Anything else? Any other suggestions? Yes.
Speaking to the Ryan White piece, some of the, from a tribal health perspective, we have examples where there has been Ryan White access within our tribal systems for individuals, but that's not the most common outcome when coordinating with our state agencies to get Ryan White dollars or new designated providers within our tribal health systems. And that plays into the fact of spouses, non-beneficiaries in the legal terms and stuff, would be able to stay with their partners, spouses, and stuff for treatment together if those individuals could be covered by Ryan White and seen by that tribal provider in those pieces. So it plays into a retention and care, viral suppression piece, and being able to have more Ryan White providers outside of these large academic centers that we see in some of the states.
Great. So we have increasing Ryan White care access with retention and having Ryan White providers outside of. Okay, that's fine. Increasing Ryan White care providers essentially and having more access. So thank you. Okay. Thank you. Any other recommendations for improving health outcomes? Yes.
I think another one, and thank you. I think another one, but also making sure that all staff are trained in regards to the same information that's being provided. I know right now a lot of healthcare facilities and integrated care facilities have a high turnover rate, and some aren't educated or trained adequately enough to provide the appropriate or the accurate information. And also just making sure that they implement cultural humility rather than competency in that aspect as well.
Thank you. Yeah, there's definitely a need for increased cultural humility in the provision of care, and we need more providers generally, I think, across not only HIV, but just across like all communities. There is definitely a provider shortage that we've seen. Okay, any other suggestions for improving health outcomes?
Sounds like we have one online.
Oh, one online.
Hi, this is Terry Wilder. I think one of the things that's important to remember is that by 2030, 70% of all people living with HIV will be 50 and older. So when we're thinking about that, there is a lack of gerontologists in the United States. So how are we going to make sure that the community of people living with HIV have access to some of the specialty knowledge that gerontologists have? And to kind of piggyback on the importance of clinical education, how do we make that happen? Like, how do we make sure AETC has the dollars they need to expand, to make sure we are training our HIV providers on frailty screens, on how do you do a DEXA scan? AETC never has enough money. So how do we make sure that they get that money so that it's not these kind of passive, and I'm not being disrespectful, passive kind of, just go to a website and watch a video on, geriatric HIV care, but it's something very proactive where people can be at Project Echo on this topic. They can have a preceptorship where they shadow gerontologists or, folks who are experts in HIV and aging. I mean, we really have to think about how to make sure that this workforce issue really is trained on HIV and aging, and that they really have more active learning versus kind of passive learning.
That is a really great suggestion, and I really like the recommendation to use ECHO as a platform for getting more specialty providers or more providers knowledgeable on geriatric issues. I think that's a really great platform and recommendation.
Thank you. I used to run one. So I cheated.
Yes.
I like to also add on to that and add on to what Terry and Kelly mentioned as well. I think it's so important when we talk about training for cultural humility and the training that was mentioned around geriatrics and the aging population, that it's ongoing training that's being done, and that it's not just, one training, particularly around cultural humility. We know that, things continue to change. Our thinking continues to evolve around that. And there needs to be dialogue that's happening so that we can identify some of the implicit biases that, we all carry, right? And being able to address those. And that doesn't really happen with just watching the video. There has to be that dialogue and really that challenging thinking. So.
Definitely. So the ongoing discussions, learning opportunity. I think that's where ECHO is a great platform. It can be as often as weekly or monthly, on various health issues. So I think would be a really good platform. Sure.
If I could continue just a little bit of the conversation around HIV and aging, but please go ahead.
So just wanted to build on the comment around providers. And so I think oftentimes we talk a lot about the existing sort of healthcare provider workforce. And so as the dean of a school of nursing, I'm typically thinking about the future workforce. And to me, there are a couple of trends that stand out. One, we see that there are fewer and fewer people, whether it be in medicine or nursing, physician assistants, who are choosing HIV as a specialization. So we've got to get to the schools and try to ensure that we have the pathway or the pipeline. And I would also say that if we really are serious about ensuring that they're well trained, then we've got to ensure that the curricula and actually the licensing exams that we take, that they prioritize this content. Because if it doesn't, if they are not being asked to consider this content, then it's not going to be relevant to how in our early formative phase, it's sending a message that it doesn't really matter.
Can I just make a quick note for folks online? We really want to hear from you. Please, if you have comments, put your hands up opposed to the chat box. Hearing your voice will help with the dialogue and continuing the conversation. And so I did hear there were some comments in the chat. And so I'm just going to pass it over to John and Laura, but please, if you commented on chat, please do raise your virtual hand. Thank you.
Yeah. You want to comment?
Well, I was just wanted to echo what Vincent just said. A lot of this begins with education. And then I want to make sure that we highlight the fact that it's not gerontologists. It's clinicians, primary care clinicians, who not only nurse practitioners, PAs, but family medicine physicians and clinicians, internal medicine, not special. That's a specialty in itself. And so recognizing that all of these individuals are educated and need to be even educated to a higher degree on individuals living and aging with HIV. So just want to, get that term gerontologist, kind of push that to the side and say that all clinicians who care for individuals living with HIV and aging with HIV are educated as they get older. So.
Thank you for that. And I interrupted the conversation. So with the Ending the HIV Epidemic Committee, one thing that we have done is engage in a series of dialogues around HIV and aging. And we're continuing to formulate what PACHA's response will be to that particular issue and continuing that dialogue. And I'd like to, if we could just interject a little bit, continue that dialogue right now. I will share that we've had some great comments around the aging people with HIV returning to the workforce and the education and development they need in that regard and the resources that they need in that regard. We've had conversations with folks who have talked about AIDS survivor syndrome and overcoming challenges there. We've had folks discuss today the issues around provider education and actually providers providing that service. And we've also talked to medical providers like the Yale School of Medicine, who initiated a completely different methodology around how they provide services, from wait times to hours to who does it to how long you spend in the clinic, and really recognizing the importance of some of the extended care that folks might need, including referrals and what have you. And we've also heard that feelings of being overlooked and having less priority than younger folks who are acquiring HIV and the services that are really going to them, that could also be going equally to people who are aging with HIV. So I thought I'd open it up to comments both in the room and online. Any additional comments around aging with HIV that we can take back to the committee? And it looks like we have an online comment. Wanda? Hello, Wanda. Comments?
Can you hear me?
Yes, we can.
Okay, excellent. Wanda Brindle-Moss. I'm from Winston-Salem, North Carolina. I happen to be an RN retired who is living with HIV. I find the points and the comments about aging with HIV very valid. And I also am concerned about the health care that is being provided, because my providers are getting younger and younger and younger. And oftentimes they tend to not realize that I know whereof I speak, that I am the guardian of my care, that I am the expert on my health care. And so all of our providers do need to be trained from med school forward on aging. It doesn't need to start as an afterthought. It needs to be a forethought.
Thank you for that. I know as a person aging with HIV, some of the folks that have walked into the room to provide care seem to be getting younger, and I understand your challenge with that. Yes.
I think one big piece that sometimes we forget or we think isn't valid with an aging population is prevention. We maybe think like all of that has to start when you're, in elementary school and, brush your teeth and, these kind of like preventative messages are still very valid. People are living long, full lives with HIV. The picture looks very different than it did 30 years ago. And so, incorporating more prevention and helping people in that way, I think is ultimately really important. And I come from a community health background. I was a community health educator for a long time before I became a nurse. And oftentimes with nursing, we think of the bedside nurse. I think our bread and butter, and we've been saying this for a long time, is prevention. Is the key to everything, really. I mean, that's all I had.
Thank you, Jennifer. Any other comments? Yes, over there on the other side. She's coming with the mic right now.
Okay, complete random thought. We know that syphilis came back with Viagra. Is there a way to put a warning on our PDE5 inhibitors that please take precautions, does not prevent against STIs and HIV? Random thought.
John? I'm not going to touch that one. In terms of aging, I think, and I'm sure the data are there, I just don't know what they are. I think we have to look at the data to see, for those who are living with HIV, who truly are not living as long, right? What are the disparities there? Make sure we understand those and figure out what we need to be doing to assure that everybody has essentially that same ability to live as long on HIV or, with HIV. So again, back to the data back there, making sure data are driving our look and thinking around this.
Thank you, John. We have 2 more people online.
Yes, this is Doug Rose. Can you hear me?
Yes.
Oh, great. Okay, good. This is Doug Rose. I'm speaking to you from Baltimore, Maryland. I'm a person living with HIV and a person surprisingly aging with HIV, something I didn't really plan for. So it's sort of a whole new challenge. But, there's been a lot of talk about testing for people with HIV, testing as a kind of prevention and testing as a kind of awareness raising and all of that, which I think is just great. I think, people of all ages should be tested for HIV. One of the problems is it's not happening at any age. There are millions of people in this country who are never, ever, ever tested for HIV. Despite 20 years or so of the CDC recommendations that everyone be tested routinely for HIV, it's not happening at any age. It just isn't. I was at a recent meeting with the epidemiology person at the state of Maryland, and he tried to make a point to us that, that we need to do more targeted testing. We need to do more targeted prevention efforts. And he showed how we could save money by showing us how community testing might need to do, 800 tests to get 300 positive tests. Whereas in medical settings, you would only have to do 400 tests to get 300 tests. And that raised 2 very serious questions for me. First of all, in a medical setting, someone's coming in who's sick. Chances are good that sick person is going to test positive, depending on what the illness is. So that's a very good chance. In the community, you don't know. People don't necessarily present as sick, so you don't know. But even a bigger question is, why is the medical profession missing those 300 people in the community that go through community testing? Because they're not following CDC recommendations. And we are hearing an awful lot about how we have to follow CDC on molecular HIV surveillance and this and that, but nobody is saying, why are we not testing routinely at all ages? And I think that's something that really has to be paid attention to. And I know, the medical lobby is strong and, doctors don't like to be told what to do and blah, blah, blah. But you know what? The disease continues to spread. And just collecting the names and addresses of all the people who are HIV positive is not going to stop that. So I don't know. That's my thought for the day. Thanks.
Thank you. Thank you for your suggestion for testing at all ages. We have another person online. Terry?
Hi. Just a couple of things when folks are thinking about prevention. Several of us talked about the need for removing the upper age limit for the CDC HIV testing guidelines. We hopefully shared very concretely why that's problematic. But I think the other thing to think about is that, would love to have the CDC do a campaign or do funding for a campaign around prevention for older adults. I never hear anyone, when they're talking about a national PrEP program, talking about older adults. Never. And so thinking about PrEP for older adults and also thinking about that older sister, PEP. The other thing is, when we're thinking about training, I think we should also think about social service providers and making sure that they are prepared to take care of folks and provide services to folks that are aging with HIV. One of the things that I'm finding in my work is that the HIV community is over here and the aging community is over there. And it would be lovely if we could create a space, a conference, a meeting, a convening, a town hall for us to all be in the same space together to share best practices and things so that we can really collaborate together. Because folks are starting to show up at some of the services that our senior citizen centers are providing or some of our offices on aging are providing. And I want to make sure that my friends and the people that I care about are going to be treated with respect when they enter those spaces that maybe they historically have never entered before.
Thank you. Thank you for your suggestion to have older adult PrEP programs as well as having a place for people to share resources on what they're doing. Any more online? Oh, one more. Okay.
Hey, this is Scott Brittany, and I'm the Director of Advocacy for Health HIV and lead the National Coalition for LGBTQ Health. John, former Secretary Wiesman, you might know me as the previous director for Lifelong, where we worked on the STI modernization bill and all the work that we did with Tamara and whatnot. But I did want to echo your comments about more original data. It really does need to be conducted. And the council should take heed to all of my colleagues' former comments about, taking that innovative approach in source data and data that also includes, health equity and all the social vulnerability metrics and all the qualitative and those qualities of life that really tell our story. And to the health outcomes conversation about earlier, in addition to healthcare training, we need to be thinking about workforce burnout and people that are retiring these days. And, as an HIV positive person myself for 30 years, I've had one or two ID docs throughout the journey of my story. And as they retire, we need to be training more specialists, and medical schools and residency programs really should be encouraged to focus on HIV care as a specialty these days. And we should really expand the role of non-physician providers and nurse practitioners and physician assistants and all those registered nurses, those social workers that can play that critical role in providing HIV care. And we should probably further emphasize things like task shifting, about training healthcare workers to perform different tasks outside of that and looking at further alignments. That also means telemedicine And it means retaining a lot of these older physicians like we saw within COVID to remain in practice longer, to continue to offer that courage for those new specialists that are coming online. And that speaks to mentorship and collaboration, and then clearly community health workers. And I really just wanted to echo many of the colleagues like Terry's and Doug's in the conversations earlier. I really appreciate that.
Thank you, Scott. We're going to move on. We'd like to talk a little bit about integrated coordinated efforts to address the HIV epidemic. And I think specifically I might be interested in, and I think PACHA might be interested in, looking at the status neutral approach. And if you don't know what status neutral is, that's looking at entry to care regardless of your HIV diagnosis. So right now, if you have an HIV diagnosis, we are rapidly getting you to a medical appointment, ideally within 7 days of your diagnosis, even more ideally within 3 days or even the same day of your diagnosis, having your medications prescribed at that first medical appointment so that you're taking them right away, having the support of case management and supportive services and peer navigation as you enter and engage in care, and then ultimately achieving viral suppression as quickly as possible and maintaining viral suppression over time. And for quite a long time, I think on the prevention end, and this is my personal opinion here, we've had that negative test event, and there's been discussion about prevention options, and now we're discussing around PrEP, but how can we mimic that care engagement on the prevention side so that you're having a negative test event, you're being engaged with peers or a case manager, you're being evaluated for PrEP or other appropriate prevention options for you, you're engaging in some sort of ongoing case management or supportive services, and ultimately you're remaining HIV negative. Any thoughts on how we can improve that prevention side of things, or I don't know if improve's a better word, but take something that people are doing a great job at and helping them do even greater work. Ada?
No one else was saying anything. I think it's really important, number one, is that we have funding and have some kind of mechanism to be able to pay for those resources. I've heard something said many times is that individuals who are living with HIV have better care than individuals who have other chronic diseases like diabetes and hypertension because of all the services that come with individuals who are diagnosed with HIV, case management, prevention, medication, ensuring that all those things are being ensuring that
Hello?
Hello?
Can you hear us?
Okay. Hello?
Oh. No, not even working.
We check 1, 2.
We can't hear. This is not being recorded, so we can't have it keep going. We gotta figure out something.
Hello?
Yeah, so this is on, and it's not over here.
Hello? Hello? Test. Hello. 1, 2. Something happened. Hello? Hello?
We apologize for this. This is very unusual.
One second.
It can't just the issue. If you mind, everybody stand up. Those that are getting scratched.
Are you talking right now?
You know, that's all I got. Interrupted the audio system. She did have fixed as soon as possible. No worries.
We can stay patients here. That's why the summertime. So bring that in there for great stuff. Yeah. Well, it's just if something
online and here my so we're going to violate the rules and folks online should be able to hear us. We will not be able to hear that, and that there be.
I think they can hear
that now. So we will continue with, and I guess we should probably continue even though you're not going to hear. Okay. And so then we chat about it. Yes, I can do that.
I can.
So
go ahead, John.
we're okay?
Yeah. Talk to the mic. You have to talk loud.
All right. So Ado, I'll take it back to you.
So hopefully I can remember what I was saying. But the important part is funding needs to be placed in that space. Because again, if you do not have the capacity to pay for that resource, then you're missing an important point. And my point was that, you hear many times that individuals who are living with HIV have these wonderful resources. They have case management. They have adherence counselors. They have so many resources that are available to them, whereas other individuals with other chronic diseases, such as diabetes or hypertension, do not have that ability. And so the same will follow with individuals who test negative for HIV. How can we have those things available to them without the money to be able to do so and to pay individuals to be able to provide that care? So again, it goes with things that we have talked about many times before, and that is having the available funding resources to be able to accomplish that goal.
Thank you. And then over here.
To that point about funding, so some of the programs that you got to see that are going on in Indian country right now, such as the I Want the Kit partnership, which is STI testing and the HIV self-testing, part of that infrastructure is reminding someone after 6 months that to order again. They can order again as many times as they want or as often as they want after they complete one of those requests, but it's that reminder piece. That whole system was built off this grain of salt and is maintenance off this grain of salt of funds that competitively is written for and asked for in a hodgepodge from RIC and Minority HIV/AIDS Fund and CDC Foundation and private funds that were built up. And to name drop, Emory and a big academic center got $8.9 million a year for 5 years to do HIV self-testing. And I am so hopeful it's very successful, but in the state of Oklahoma, Native Test is the primary HIV self-testing program because the state built one and it didn't work. And it was web-based, just like the new self-testing program that Take Me Home is. And we see that within the tribal communities and just rural America in general, some statistics on that, 48% of rural Oklahoma, that's the average, 48% of rural Oklahoma doesn't have what is considered standard broadband access. And within some of our counties, it's 75% don't have standard broadband access. And so to the funding point, the program that you saw there, the Native Test, which can be adapted to other names based on how it was created, it was meant to be adaptable to communities so that they can change the name, but the infrastructure is the same. The funding is going to piloting new or promising practices when we have practices that are established and are making a difference in pieces. And I don't even know what $8.9 million would even look like on that program like that. I'd just be going door to door. Hello, here you go. But I think that was a great point of if funding goes to the right places, those systems are in place to add in that reminder, that stay in care on the prevention side, that initial interaction. So that was a great point of bringing up funding.
Great. Thank you. Carolyn, we'll take your mic. Any other comments around status neutral? Did we have any comments online for that? No? Then I'll turn it over to Laura to close us out.
Yeah, we just wanted to also just give the opportunity for just open discussion about anything that you would like PACHA to know. This is the PACHA to the community session, or PACHA to the people. So, anything that you want to share, recommend, suggest to PACHA, we would love to hear. Any comments online?
one comment. This is my first PACHA meeting. I'm very grateful. I'm getting to interact with people that I've read and used for references on papers I've written, and for SOPs establishing in my organization and different pieces like that. So I'm very grateful for the opportunity to even be here. One thing that has kind of struck me a little bit from these conversations and the people I'm interacting with in the room, coming from a stance of working in Indian country, there's also this very rural component to a lot of it. And I feel like that's being left out of a lot of conversations right now, with being from Oklahoma as a phase 1 jurisdiction because of our rural transmission. I think, and I'm also from I'm from one of those 75% no broadband access counties originally. And that's where my family resides. And the rural point of view on what every point that was made throughout this entire day of meetings and recently, there's another component that I don't feel like is being hit on very well, and that's that rural aspect. So I just wanted to plug that.
Thank you for highlighting our rural communities and the special needs that they have. And I think we did hear that a little this morning from Mr. Curley. So yeah, so we want to hear more for raising that. Anyone else?
Gary, after these days, statement or resolution on moving or age limit of the CDC HIV testing guideline, the community has been asking just for years, and it's time.
So Jerry gave us the comment supporting removing the upper age limit for CDC guidelines for testing.
So I had a comment with our CDC, I had a conversation with our CDC representative at break, so I'm going to turn it over to her.
Thanks, John. Can you hear me?
Let's have you, the mics aren't working. So.
Oh, the mics aren't.
Yeah, here.
Thanks. Is that working? Oh, okay. Okay, thanks so much. Thank you, Terry. I just wanted to let PACHA and the rest of the community know that at CDC, we are working on updating our HIV testing guidelines. It's undergoing a very rigorous update process. Some of the key topics that we are looking at include age intervals for screening, revisiting, looking at increasing the upper age limit, as well as screening frequency, reviewing once in a lifetime for general population. So this rigorous process includes a systematic review, looking at over 13,000 studies that have been identified between 2006 and 2021, and using the GRADE approach. The next step will be synthesizing evidence and drafting recommendations. I just want everyone to know that this is ongoing. It's a lengthy process. It's rigorous. We do not yet know if the updates will impact the current age range, but those are two of the main key topics that we are exploring at this time. Thanks.
I don't know that I could repeat that entire thing, Carol.
Sorry, I was going to say we have 1, 2, 3 in the audience.
Okay.
Sorry.
Just put CDC updating that.
Yeah,
Okay, I wanted to piggyback off of the Oklahoma rule. So I'm from Arizona, born and raised, lived here my whole life, and I work in Southern Arizona. So at least within Arizona, our rural counts for 50,000 people in the population that designates as rural population. Our counties are facing a severe health professional shortage area. And within Arizona, we are only meeting 39% of needs for primary care, and 8.4% of behavioral health care is being met as well. Within Southern Arizona, at least, we know that here in Maricopa, it is the most populated county here. It's getting the most funding for HIV, but we're not seeing that trickle down into most of any of the other counties. So it's leaving us with lack of funding, lack of service locations entirely. And as well, to go off of that point from earlier about privacy, it's the same thing. Within the county that I work in down south, not going to name it, there's only 2 hospitals. So it's a really big issue for someone to go in, at least get tested, and then as well for the county health department, we don't have accreditation yet, at least. And within the smaller rural ones, it's not a common thing. I'm not sure if that's funding or just lack of time or effort, but within our county health department, our patients can get tested for HIV. And if they're positive, they are then referred to one of the hospitals within the county. And to me, when I started working there, that blew my mind, because why is a county health department not having the service or availability to treat HIV positive? That's it.
Thank you for sharing more about the needs in rural communities and what you're experiencing in Arizona.
I would just say, as part of like the lived experience, and since we are specifically focused on our discussions today within Native communities, is a challenge maybe to members. I don't know how this would roll out or look like, but visiting some of these communities in person. I lived on the reservation in Tuba City for almost 10 years, working there as a nurse in a variety of different capacities. But the stories like we heard from Rydell, of course, I talked to him. He sounds the same on the phone when I call about coordinating care. He just has this effect. You just kind of pause and slow down. And I'm reminded of when, I lived on the reservation, and, the respect and the reverence for the communities that we're impacting and making big decisions for. It makes it real to, so I don't know if you need to take a vacation to the Grand Canyon, but just make your way across the Four Corners and just, talking to people and really seeing the challenges. I used to drive to a really remote clinic, Denevito Clinic, once a week. It's a dirt road. We'd have, flat tires, and, these are real challenges. Giving a patient a ride who just got discharged from the ICU to their home, that's 45 minutes away, and the patient's going to hitchhike home. This is like reality. Or picking up a mom on the side of the road with, it's the only place I pick up people on the side of the road, by the way. Carrying her baby to the clinic to get seen, and it's winter, and real challenges of meeting people where they're at. And I appreciate you all speaking from your own community and experience, but also as healthcare professionals too. It's important to, we're in Phoenix. It's beautiful. This hotel is gorgeous. I've done staycations here before. But I don't know if that's something that you guys have ever done before. I know you have limited time, but I would just challenge you to, and maybe some of you already have. So I'm making a lot of assumptions here, but it makes it much more personal. I've been very touched emotionally today. I think, I'm getting a little more emotional, but the effects that COVID has had on our healthcare system, and a lot of our patients who've been out of care for a very long time, and coming back in and just seeing the losses of, we've worked so hard over many years to get people to where they are, and we have a long ways to go. So anyways.
There was one more comment. Oh, it works now. No?
I think we're at time. Is that right? So just want to say thank you to everyone who provided comments today. We PACHA members really appreciate these sessions. They're fairly new to the PACHA meetings, and we really enjoy hearing from you all in this interactive way. So I'll turn it back over to our chair. Did you want to say?
I just wanted to say, if you could give a round of applause, if you're anyone who's been aging in any way, please give a round of applause for Kat and Stephen, our Vanna White, and Carol Merrill. And thank you very much. We'll go back to our regular meeting.
Great. We're gonna just stay where we are and wrap it up right here. So this morning, Marlene and I forgot in our introductory remarks to mention that yesterday we did do some site visits. We had the opportunity to go to the Southwest Center, to the Phoenix Indian Medical Center, and to Native Health. While I know those aren't out in the rural, we did have an opportunity to go visit, see what services are being provided, hear from folks who are providing those services directly. Sometimes we also hear from clients on these visits or other people who are being served. We appreciate folks allowing us to come into their facilities and into their programs, learn more here directly. In September, it was going to be a virtual meeting, but after our last PACHA meeting, we have decided to go visit Appalachia and actually get into our best as we can into a rural community. And so we've not made the determination exactly where it's going to be, but that is going to be our plan. So those of you who thought we were having a virtual meeting, it's going to be in person, which we're thrilled about. We also, in the past, early on, went to Jackson, Mississippi, to get a sense of what was happening there as well. And Carl and I will probably say a little bit more about this as we do our departing thoughts as the folks who were the first co-chairs of the reconstituted PACHA, some of which is about going around the country, because that's not what PACHA had done before. So apologies for not mentioning the site visits earlier, and I'm hoping that PACHA members tomorrow, when we do our sort of reflections around the table, that any reflections you have on those site visits as well, that you will incorporate those into your comments and into your thinking. Tomorrow, we're going to be spending our time talking some more about HIV, AIDS, and the response here in the greater sort of Arizona, broadening from our conversation around Native American and Alaskan Native, American Indian and Alaskan Native issues, which again, very much appreciate our speakers. I think this was a very moving day. I think we learned a lot about things that we didn't necessarily know about sovereignty and about political status and other things that then can help inform the stories we've heard, the lived experience, and really appreciate folks lifting that up and bringing it into the room, which is really important. We will do some reflection tomorrow about what we heard as major themes and where we might want to go as PACHA around this. We usually work in subcommittees in between, and so what of these issues might go to a subcommittee and do some more thinking and what that might lead to. So tomorrow we will do all of that. We will hear from the subcommittees and some of the work they've been doing in the meantime. And we will, as I said earlier, have a little bit more to say about the molecular HIV/AIDS surveillance. And we'll hear a little bit about what the, I always get the acronym wrong, so let me just look it up. What the CDC HRSA Advisory Committee on HIV, Viral Hepatitis, and STD Prevention and Treatment, also known as CHAC, is thinking about in terms of HIV workforce, which is something we have talked about in the past as well and have more work to do on our end. One of the things I want to give PACHA members a heads up on is, based on our site visits and earlier conversations today around syphilis, I am going to work with a few folks to try and craft by tomorrow afternoon a quick resolution around syphilis and the importance of acting quickly at this point and thinking about what we might put in that. It will not be a full 3-page, 2-page, whatever resolution. This is going to be, I think, something to make sure that this is moving forward at the federal government, some quick advice we can give to the secretary. So expect to see a draft sometime tomorrow. We'll give you a heads up about it, and we will try and see if we can get something passed tomorrow. So we'll keep it shorter than longer. So there's less wordsmithing, and we just maybe, and while we haven't spent, many hours talking about what we would want, let's get something started is going to be the plan. Let's see. I think those are the things I wanted to just make sure we close with. Let me look to Caroline and Kay. Are there any things we need to do on this end? We're good there. Get some rest, yes. Also, just a huge, I know we'll do this tomorrow too, but to make these meetings happen, one, thank you for coming. It is really important that you're here, that you can hear what's going on, you hear what we're hearing, you bring your lived experience here. This is about the people, and it's important that we have that visual presence and that we keep us all grounded in that. So thank you for attending, taking time out of your day. If you're available tomorrow, we would love to have you join us as well tomorrow, same place. But I also want to do a shout out to the tech folks for all of your help. You all make this happen. You respond quickly to things and problem solve. Why are the mics not working? And it is nothing that we have control over. And so I can't believe how quickly they figured out that a building fire alarm system was preventing sound in this room. So well done to you all, and to the PACHA staff who make this happen. All of our contractors, to our fellows, everybody, thank you. And with that, I hope everybody has a restful, safe, fun night, whatever that is for you. And we'll look forward to seeing you again real soon, if not tomorrow. Thanks.
Produced by the